The next joint that we're going to do our exam on is the shoulder joint. The shoulder joint is a lot like the hip joint, where it's a very complex joint, testing multiple areas. So I recommend kind of coming up with a normal flow or routine that's different than your inspection palpation format, just due to the fact that you have so many things to test to do a good shoulder exam. What I like to start with is actually range of motion testing. So what I have the patient do is start with abduction, bringing their arms out to the side, and then up over the top of their head. If you see any restrictions there, this can give you clues into what may be causing some of their problems. I also like to do from the front, doing forward flexion, having them bring their arm all the way up and seeing how far they can get there. Once I've done those tests, I then like to actually do a little bit of my NIRS test, where I do some passive testing up at the top to see if this changes or recreates some of their symptoms that may be consistent with impingement. Following that, I then have the patient very, very slowly bring their arms down, and what I'm watching for here is scapular dyskinesis, or winging of the shoulder blade from one side compared to the other. These things can help give us a clue, as the shoulder blade is often a key component into their shoulder pain and leads to compensation. After observing both those things, I then like to come back and test their external rotation. So arms at their side, rotating out. Once they're here, I like to then test the strength at that external rotation, making sure there's no deficits. I then have them go into internal rotation, where we see how far they can reach up into their thoracic spine, making sure both sides are equal. To test their subscapularis, or internal rotation, what we like to do is have them put their hands on the belly, because the test behind is often painful for a lot of patients. And what you do is you press into their elbow, making sure that they're not bending at the wrist to maintain good strength at the shoulder. Once these have been tested, I then like to do their strength testing in forward flexion at about 30 degrees. So having the patient come forward, coming into that plane of 30 degrees with good closed fists, I like to push down. If there's no pain or symptoms there, I will then do their empty can test with their thumb pointed to the ground. Following that, I then like to go into my other passive tests. So I go back and see if their shoulder motion is any different as I take them all the way up into forward flexion. This will also be another chance to look at a positive NIRS test or sign of impingement. Another test that's beneficial for impingement is the Hawkins test. So putting them at 90-90 position, level with the shoulder, you then do slight internal rotation, seeing if that recreates their symptoms. If you have any concerns about their AC joint, now is a good time to palpate that area. I also like to do the cross-arm test and see if this recreates pain at the top of the shoulder. The other thing you can do is, if you're concerned about the AC, is have them do a resisted motion with the elbow up against you to see stressing those ligaments if that recreates pain. Following that, I then like to test my cartilage inside the shoulder joint, looking for any labral pathology. One of the better physical exam tests that we have for this is the O'Brien's test. Similar to the empty can, we now bring them across the body a little bit further, thumb to the ground, doing resisted motion. And then we'll have them turn palm up as this rotates the ball out of the joint so that it's not loading that cartilage as much. This then have them push up resisted motion. A true positive test is pain worse with thumb rotated to the ground versus palm up. This then takes me to testing their biceps tendon, which can be a common source of shoulder pain. I like to start with my speeds test, just having them push palm up straight up to the ceiling, and then transition to my Yergasons, where we will have them do resisted supination against my hand and grip. I like to pull down on their biceps tendon distally, but it should recreate pain in the proximal portion. If all of those tests are okay, I then kind of like to take a look and see and make sure there's no signs of atrophy or changes, as sometimes there can be an impingement upon a nerve leading to further issues. The last part that you test for is any shoulder instability, and I'll have the patient lay down for this test. Once the patient is in the supine position, I like to start with my apprehension test by placing my middle finger on the posterior aspect of the glenohumeral joint. You then have the patient go into their normal range of motion for external rotation, and then I'm going to assist by taking it a little bit further. If they feel like their shoulder is going to pop out of joint or this creates pain or instability, that is a positive test. The relocation test is similar, but you're now going to add anterior counterforce to make sure you stabilize that ball in its socket, and then we're going to apply that same force. If they have less pain or symptoms, this can be a good sign that the patient is having shoulder instability. Another test in this position is a load and shift test. This can be a difficult test to do, but is very helpful in figuring out how much instability the patient has. You're often compressing down the humerus, loading the joint, and seeing if you can get any areas to feel like they sublux or pop out of joint. Another way to do this test is to then have the patient relax with their arm across the stomach. You then grip high up on the shoulder, stabilizing here, and then using your thumb and middle finger, you can actually translate the ball back and forth, seeing how much motion they have compared to the other side.